the conceptual basis of urology course. And we have a very good friend. All of you are aware of him, met him, Dr. Zeeshan Aslam from UK, and he will be our speaker tonight. So I'll start off with a case that we are currently managing. And I think that is just a preamble to what we are going to talk about this evening. So this is a 51-year-old male. He had hematuria for the past 4 months, and he has been disregarding that. He's a known hypertensive until the time that he started developing shortness of breath, loss of appetite, and he says that he has lost about 5 kilograms in the last 1 month. When he presented to the clinic, his examination was essentially showing a left flank mass, slight tenderness, not really a mass, and his rectal examination was unremarkable. His basic workup at that time showed hemoglobin on the lower side, WBC count slightly on the higher side. The rest was pretty much normal. His kidney functions were okay with a creatinine of 1.2. Estimated GFR was over 60. Slightly low sodium and chloride. His clotting profile was normal. And since he has shortness of breath and some chest X-ray appearances, we did a COVID test, which is probably mandatory at the time of coming to the emergency room, where he presented subsequently. And at that time, when I saw him in the clinic, and because of his shortness of breath and because of the chest X-ray that he had, which is showing partially collapsed lung on the right side, we did a examination, showed some dullness in his base on the right side. We put a tube, a drain, and effusion was sent for analysis. The report is still not available. Now I'll just show you the CT scan, and we can have then some comments from you guys. So is my CT visible?
Yes.
Okay. So these are the chest cuts, and I would like the residents particularly to keep noting down and writing in the chat box the findings that they are seeing. So we are looking at the lung, the chest cuts, and we are watching them in the chest windows. So if you focus on the lung parenchyma and the space, the pleural space, there are a lot of findings around. So I would appreciate if the residents can write down these findings. I'll just go through rather slowly. So you can see this in the mediastinum, in the pleural space, and the lung parenchyma. There are findings. So please write down in the chat box as you see. Coming down, he has significant consolidation and collapsed lung on both sides with pleural effusion. Let me share the abdominal cuts. And these are his abdominal cuts. Again, I would appreciate you guys to see and write down as you, and I'll comment on them subsequently. So focus on the left side. So there are findings again in the kidney, there are findings in the hilum, and there are findings along the aorta, the periaortic space. So all these findings, please write them down. And these are something findings in the aortocaval window as well and paracaval. So there are in all at least 10 significant findings. And let's see how many of you pick up those findings. Going back. So this is something which is not very unusual. And these are cases that we see on a regular basis in our clinics. We have been treating them in various ways until two major landmark studies, the SURTIME trial and the CARMENA trial, and subsequent analysis and reanalysis and meta-analysis that has come. And Dr. Zeeshan Aslam, who is our speaker and guest tonight, he's a consultant urologist at Ninewells Hospital in Dundee, Scotland. And he's a big supporter of our academic activities. Most of you may have had the benefit of attending his laparoscopic hands-on courses. So welcome, Zeeshan, and thank you very much to be here tonight to discuss these and similar cases and how should we go about. So I stop my share and please go ahead and share your slides.
Right, just need to, right. So, well, thank you very much, Professor Hamad, and for once again getting us involved, inviting us. Are my slides and my audio okay?
Yeah.
Yeah, fine. So, yeah, thanks. It's great to be again part of these academic activities, and thank you very much. So, cytoreductive nephrectomy, as Professor Hamad has already mentioned about these couple of trials and how the dynamics, the approach has changed or not really changed. That's what we are going to discuss today, and what kind of patients could benefit most. So as already introduced, I'm a consultant in Ninewells Hospital, a Dow Medical College, Dow University graduate. So these two trials, mostly CARMENA, will be the main topic today. Okay, right. So I think I'll move with this. So who is an ideal candidate for cytoreductive nephrectomy? So this is a dilemma which has always been there, and I think it is still there to some extent. If I go through my own history, my own urological training and career history, I graduated from Dow University in Karachi, then moved to UK, started urology in 2006. It does take a little bit of time to get into urology there. And then my first literature analysis was with Phil Matthews, who was a leading renal cancer surgeon in UK, now retired. I wrote a commentary on cytoreductive nephrectomy. And then for the last like 7-8 years, it's exclusively renal cancer practice that I've been doing in later parts of training and as a consultant. And then Baus did some audit for cytoreductive nephrectomy following CARMENA trial. And they have collected data recently for a follow-up, 2 years follow-up for that. And if you just see, I mean, I didn't realize it myself. It turned out that I was doing more than most all across UK. There were 6 cases I did that year of cytoreductive nephrectomy. But with all that, again, the question remains, who is the ideal? That was the whole idea of me going through that. Who is the ideal candidate for cytoreductive nephrectomy? So this is, in this talk, what we discuss is a lot of these is based on experience, opinions, rather than criticism on these trials or what different groups believe in. So very quickly, few facts that RCC is a very lethal cancer, and patients present with metastatic disease in a fair bit of proportion compared to often to prostate cancer or pelvic cancers. And there's a high proportion who go on to develop metastasis as well. I think up to 50 to 70% in high-risk disease in over 5 years. So risk stratification wise, a very quick review that Memorial Sloan, this is something which we have been following where we look at performance status, hemoglobin level, time from diagnosis to treatment, and corrected and calcium and LDH level. So some blood parameters, and then patients are divided into these 3 risk groups. And that has suggested that the 3 or 4 or 5 risk factors group, the black one, you can just look at the time for survival, proportion of survival. So which means it's a very poor disease, and that is in context of systemic treatment. These results. So IMDC score in International Metastatic Disease Consortium, or HENCH criteria, by a Canadian group. This is something which we are using more commonly, and that again is pretty much similar with performance status, and then more blood parameters, platelets and neutrophil counts into that as well, and then time for diagnosis and yes, yeah. So these defined into low, intermediate, and high risk group. So again, this is a picture of how aggressive this disease is. That median overall survivals in first and second line RCC according to IMDC risk groups, and you can just see that in unfavorable group how poor the survival is, and that's with first line and second line treatments. So that was not in the cytoreductive these are not figures related to that, but just from a systemic treatment point of view. So where does the role of surgery comes in metastatic RCC? It comes in 3 different ways. One is cytoreductive, and we have already known it very well: good performance status, resectable disease, and if majority of disease is within kidney, then you can just go ahead with that. Consolidative nephrectomy of bulky disease where tumor biology is not clear and locally advanced, unresectable disease where you have systemic treatment, and then could do consolidative nephrectomy if the outcome is favorable. And then finally a metastatic, that's for solitary oligometastatic lesions, where good resection is feasible. And after that, patient could have systemic treatment if as necessary. So with cytoreductive nephrectomy, there were a couple of landmark studies from over a decade back, more than that, where they were done by EORTC as well as Southwest Oncology Group. One of them was in New England Journal of Medicine, and they were all based on the previous immunotherapy era. Now we have a new immunotherapy era, as you must be reading about and seeing in your clinical practice. So that was interferon, and which was, my understanding is, we have never seen it in our the era which I have trained, but they used to be pretty toxic medications. And then another one in the Lancet, and that was again about immunotherapy with in metastatic RCC. So both these studies, SWOG and EORTC, has suggested that survival advantage in both these groups with surgery followed by systemic treatment. So that's where the concept was consolidated a bit more about cytoreductive nephrectomy after these 2 studies. But CRN, cytoreductive nephrectomy, what sort of factors we were considering, or what we should consider if I have to select the patient based on previous studies or the new studies? We have to think that it's not without risk. Patients with metastatic RCC who have surgery, they have a fair amount of morbidity, mortality, and there are several factors with anemia, paraneoplastic syndromes. But again, we have to always ask which group. If you just think about your practice, do you see them a lot, like patients not doing well after cytoreductive nephrectomy? So this is really important to know your practices as well. Surgical complications, because a lot of them could be large masses, and patients could have detrimental effect because if they have a prolonged postoperative recovery, then SAC will be delayed, systemic anti-cancer treatment. But on the other side, we always have to think, could SAC be more morbid than surgery in fit patients? At least this is what I think and I see. And even if in CARMENA trial, the morbidity in the cytoreductive arm, a lot of that is mentioned about cytoreductive, about these sunitinib group. So we will look at a bit of an evidence, historical again, about the patient selection, and that some of that has predates the historical trials as well. So in this patients who had performance status of 1 or higher, 30 patients, and 77% developed disease progression, morbidity, mortality related to surgery, and therefore interleukins were prevented. And overall mortality was 17%. So clearly a bit of discouraging outcome. This study, greater than 75% debulking of tumor burden. There were no CNS, bone, or liver metastasis, and that is something which is applicable as well. And a patient had a good reasonable performance status. Using these criteria on 28 patients, 93% were able to receive systemic therapy with an overall response 39 and median survival about 20 months. So this gives a bit of indication about patient selection. MD Anderson, they stage 4 cases, almost 500 cases, and 23 had T4 disease. Median tumor size was 15 centimeter, which is quite a size. And median overall survival was 6.8 months, fair bit of morbidity with blood loss. So the conclusion, survival benefit is unclear, and prognosis in this patient is generally poor with T4 disease. Number of metastatic sites, that is very important as well. Response rate to immunotherapy after nephrectomy, you can see it keeps going down when the metastasis was in the lung, bone, and multiple organ groups respectively. And it suggested that on multivariate analysis that metastatic disease to more than one site organ was associated with poor prognosis. So, I mean, these are two different things. One is that depending on which site is the metastasis, outcome was poor. So lung is better than bone. And if there are multiple organ, that is worse than either of the two. So with time, rapid expansion of treatment options and targeted therapies, which were inhibitors of VEGF signaling and all these tyrosine kinase inhibitors, which I'm not going to go into scientific details, they came into our practice, as well as the new generation of immunotherapy. So there was a need for a randomized controlled trial with CRN in relation to these modern drugs. So that led to a CARMENA trial published in the New England Journal of Medicine, which has looked at role of nephrectomy in patients presenting with metastatic disease treated with sunitinib alone or with cytoreductive plus sunitinib. So this lasted for about almost a decade. And the message that has been often taken is do not do cytoreductive nephrectomy. So that's what we are going to slightly synthesize and look into the evidence in a little bit more details in our own practices. So results were, there were 450 patients enrolled from September 2009 to September 2017. Median follow-up was just over 4 years. And it suggested that the results in the sunitinib alone group, they were non-inferior to those in the nephrectomy sunitinib group with regards to overall survival. So there was no significant difference in response rate or progression-free survival were observed. So just remember, it has proved that sunitinib is non-inferior. The aim was not to prove, or it is not suggested it is superior to a cytoreductive. So this is a bit of a chart about tumor response outcome, which I think one can go in detail if you are interested in reading the whole of CARMENA trial, which has suggested pretty much the same findings. So conclusion of the study, sunitinib was not inferior to nephrectomy, followed by sunitinib in patients with metastatic who were classified as having intermediate risk or poor risk disease. So that is something to be clear about. It does not apply to any metastatic case at all, and it does not even include the low risk disease. So what does it mean with poor risk disease or intermediate risk disease? Does it mean all intermediate risk patients should not be? Yes, I could say for high risk disease, poor risk disease, that they generally have very poor outcome, but intermediate risk disease, should all of them be denied cytoreductive nephrectomy? What is really important in this very, very controversial topic or a topic which should be, to me, taken as a case by case. And this is where we would really see everyone's input towards the end, and Professor Hamad's input as well when we finish the talk. So knowing and analyzing the evidence, that is very important. Knowing your own practice and results is very important. Know your oncologist practice. You, as a urologist, it's very important to know how your oncologist is practicing, what is their approach. And fortunately, I work with an oncologist who is very pro cytoreductive as well. And I'm also aware that these systemic treatment, they can have really nasty side effects more than the cytoreductive. If you have a procedure where you have done a laparoscopic nephrectomy, a lot of time patient goes home next day or 2 days or 3 days, and that is most of the time that's done. And that's not just my outcome, that's most of us. And then clinical judgment is very important. Focus what needs to be eradicated. Are you removing the primary tumor or the metastasis? For low risk disease, can I avoid SAC altogether? For intermediate risk, where can I remove disease bulk? And then delay SAC as much as I can. So these are the things which I think one has to take into mind while dealing with, especially with intermediate risk group. So soon after that, Dr. Robert Motz's group, this is the Memorial Sloan Kettering Cancer Center in New York group, they had came up with their analysis, which was again not in agreement with all findings of cytoreductive. And they have suggested it's a slow and incomplete enrollment. Only 450 of 576 patients planned were enrolled. So it may suggest that intermediate risk patients were not recruited and instead sent for surgery. So which means what he's trying to say is that were patients who, there may be a lot of intermediate risk patients who had cytoreductive and benefited from that, but they were not part of the trial. And he mentioned there were 24 cytoreductive nephrectomies annually just in Memorial Sloan Kettering in intermediate, whereas the number for this whole study, which is French-led, and there were lots of centers, that was pretty much the same over 1 year. The nephrectomy group had more T3, T4 tumors than sunitinib group, 70% versus 50%. So to begin with, they were more aggressive disease. And there was some contamination as well. Nephrectomy group, 17% did not receive sunitinib, and 7% did not get nephrectomy, and sunitinib, again, vice versa. So a few more, just to add to that, to the Moses paper, that the statistical power was reduced out of from 450 out of 576 patients were there. So French-led study, I mean, in UK, we do close to 300 cytoreductives per year, somewhere between 200 to 300, whereas it's a French-led study, which is pretty much the same amount of population, disease dynamics, and there were less than 50 cases per year. So where are a lot of other cases? And again, in UK, the trend is low and intermediate risk disease. Our audit will show the results, which will be hopefully this year. But generally with high risk, we don't do. So where are all these other cases? Poor risk was 41% cases in this study, but fine, I can accept that, that this is not the right group. Metastatic burden was 38% in the surgical group, and that is something which is more than what we normally go for. And in the cytoreductive arm, there were 67 who had T-stage recorded and 66 had nodal stage. So there were, I mean, there was a huge number of patients, we have to say, who did not have the stage and nodal status recorded. So a fair bit of data was, again, missing. And just to, again, I have to say, I'm not someone with a humble practice criticizing all that. This is just an analysis, comments and opinion, right? It's a brilliant study, and it has added to our knowledge in several ways. So the enrolled patients, they were appropriate candidates for nephrectomy in the opinion of the treating urologist, right? That does not necessarily mean that these are generally applicable to patients and who had intermediate disease, poor performance status, minimal primary tumor burden, and who have high volumes of metastatic disease, right? So because these patients, we don't send for nephrectomies anyways, right? So a big bulk could be that particular group who was included in the trial, and which makes it the cytoreductive, does not show the benefits of cytoreductive in the intermediate risk group. So it's a non-inferiority trial, so the results may underestimate the benefit of nephrectomy. All right, so what we will do is we will have a quick look at some of the cases, some of my cases, and we will, in the chat box, we could, I mean, residents and all our consultant colleagues, they can just share their opinion about would they do cytoreductive or not. So this is a patient who was 65, intermediate risk, and that was related to his performance status. He was a smoker and a boozer. And that was his issue. He had lung nodules. You can see one of them here, and there was another one. I have not taken the second slide, but similar size, not huge. And this was the mass, about 8-9 centimeter heterogeneous mass. So who would be keen on doing a cytoreductive on this patient? Is the chat visible? Or
please write in the chat box your opinion, and we'll forward it to Dr. Zeeshan subsequently.
All right. Okay. Okay. Great. So we'll just keep proceeding. I mean, I'm sure I cannot see the chat, but that's fine. I mean, please do. Yeah, it's here. I think it's here. Yeah. Right. Okay. So now, how do I get rid of this now? Yes. Okay. So cytoreductive. I hope it's not really obscuring the view. So what we did was that we did a cytoreductive about 4 years ago. He did not have any post-op issues. It was turning out to be a straightforward case. No sac needed, and he had lung nodules actually disappeared. So here, that concept from earlier studies that cytoreductive nephrectomy, the cancer could be producing some unknown tumor driving factor, and when you remove that, these tiny nodules can disappear. I always say that were those nodules even metastasis to begin with? I don't know, but the point is the same, that you have a patient who was intermediate risk, tiny nodules, go for cytoreductive, and you have the outcome in front of you. So this is another patient. She was 53 and had a 9 centimeter renal mass, and she had intermediate risk disease because of one of the blood factors. She was actually in England and was being asked to just lose weight, and then she moved to Scotland. It was about 6 to 8 months, which has delayed the surgery. It was about 8 to 9 centimeter mass, and at that time, obviously, her BMI was still high. And when I did a CT scan just to update things, she had a solitary mat on the rib as well. But other than that, good performance status, everything. So again, right, so cyto plus metastatectomy. It's on the rib. It's on 4th rib. So yes, possibly could be excised. Metastatectomy, right? Okay. Yeah. Second case. Great. So we do have some favors with cytoreductive nephrectomy. Right. Great. So we did a lab cytoreductive nephrectomy almost 2 years now. Home day 2. Pathology was not very aggressive. Post-operatively, she had radiotherapy to this rib mat, and there's no anti-cancer drugs required. Last follow-up, almost 2 years, no recurrence, stable appearance of the rib, no further disease process into that. So again, this is a example of an intermediate case where we have done on case-by-case selection, and often, despite that, bone mats, some oncology groups may not be in favorable cytoreductive nephrectomy, but in a patient who could have serious morbidities with surgery or SEC, I think it was all worth taking a chance and see how her disease behaves. So that's another thing, what I mentioned about clinical judgment. So this is a 72-year-old male, 5 centimeter renal mass. Yeah, that was a slightly adventurous. 4 centimeter humeral lesion with pathological fracture. It's a big lesion. A small bilateral lung nodule, and you can see one of them. Intermediate risk disease. Good performance status he was. Orthopedics have done some procedure. I think he presented when he was in Hong Kong, and then here in Glasgow he had excision of humeral lesion, and they did a fair bit of work with that, and he was actually disease-free within his arm. So here you have an intermediate risk disease, and you have a metastatic site, which yes has been surgically treated, but it's one of those where evidence slightly goes again. Cytoreductive. So again, we have any takers for cytoreductive nephrectomy here? Or would you just go on to systemic treatment? Okay, great. So yeah, fantastic. So we did a cytoreductive nephrectomy, no post-op issues. He was a fit patient. Pathology, G4PT3A, renal vein invasion plus necrosis. So it is a very aggressive disease. And even in a non-metastatic scenario, like I think over 50% chance of developing metastasis over 5 years. So lung nodules were observed, they gradually increased. And in 2020, he had pembrolizumab and axitinib. Good response, but acute hepatotoxicity had to be stopped. Started 2021. He presented with intra-abdominal sepsis, diverticulitis, and has a fistula formation. Now, I honestly cannot say that all of that was related to his systemic treatment, but they are known to cause these bowel symptoms as well. So that has been stopped. He's on surveillance now with stable lung nodules. So again, this may not be the best patient, and his disease, which started to progress after 1 year, that again should not surprise. Aggressive disease, poor metastatic features. But you can imagine if he was directly put on systemic treatment. So this is exactly what I was trying to say, that there were cases where your judgment has to play some role. Yes, in some patients, it may not turn out to be the best decision, but it may not be worse than directly putting them on systemic treatment. Right, so this is a 53-year-old male patient, 10-centimeter lesion, and had lung nodules, retroperitoneal plus and lung nodules, IMDC low-risk disease. Yes, Sana has said, can go ahead with proper counseling regarding the disease recurrence, a possibility. Yes, yes, patients have to understand all that, and they do actually about what are the risks involved with that, right? So this is a 10-centimeter about lesion in its maximum size. Yeah, so with RPLND, yes, yeah. So again, the lymph nodes in the para-aortic region, they often, as you must have noted, that they could have prognostic, they may not have effect on prognosis except just staging purposes. But yes, if you can get them out easily, then without increasing morbidity, then why not, right? So he had a lap radical nephrectomy, G3T3A on all three factors, vein, sinus fat, as well as perinephric fat. Last October 21, stable lung nodules except minor increase in one of the nodule. He's like what, over 2 years now. No systemic anti-cancer drug needed. So it turned out to be a good deal for him as well. Right. So this was a case who is an 80-year-old very fit person, 5-centimeter RCC, and had a para-aortic lymph node about 3 centimeters. So that's constitutes about one third of the total disease. So low risk, fit patient. And how about the cytoreductive here? Yeah, okay, so we went ahead and performed, there was initial decision here. Yeah, that's why I included this case, that patient would go for SACT, but then after some more discussion counseling, we did a cytoreductive and lymph node excision 2018, and he remains stable as well, and no SACT has been needed. It's coming to 3 years now. Right, so yeah, great. He's very fit person, right? And so this is another similar intermediate risk disease, 8-centimeter RCC. I haven't included the picture, bilateral pulmonary nodules plus lymph nodes. So the thing about is here, again, I'm sure most of you would just say, go for cytoreductive nephrectomy. So this is a case where, again, we have a very aggressive pathology, brain met solitary, he developed about 1 year later only. So it started on pembrolizumab and axitinib, good response, and recent scan, it is stable. That is for the lungs, and this is radiotherapy is for the solitary brain met. So this is one of the cases where, again, one can survive SAC decided initially because of his age. Right, so going back to that case, it was because of the lymph node volume. Now that is something which I did not really agree because the lymph node was very accessible. Unless there was widespread metastasis. This lymph node is very accessible, and eventually that's how we kind of changed the decision. I obviously cannot go into all the details of that, but yeah, that's how it was changed with a bit more of counseling of the patient, then discussing again in the tumor boards. Yeah, So we were here. So here, this is a case where I still wouldn't say that cytoreductive nephrectomy was a wrong call. All I could just say is that should we have considered early post-op systemic treatment based on PAP, or should we have continued his surveillance and deal with MATs as they have occurred? These are some of the answers which remains slightly unanswered to most of us as well. And this is exactly a similar case, a 10-centimeter lesion, tiny lung nodules. He was a low risk, right? So we went ahead. Again, you can see the pathology, G4T3A, rhabdoid differentiation, 12-centimeter mass. He had a lap cytoreductive without much issues. No SACT initially, but then 2 years later, similarly, parietal lobe solitary MAC, radiotherapy has been done. He's stable so far. So same questions come here again. Should we have considered earlier SACT, and we can discuss this towards the end of the talk. Finally, this is a case, a 57-year male who had a 4-centimeter lesion on a scan done, ultrasound scan, when he presented with the cholecystitis. So he presented again June, large mass, and I have to move this. So this is the renal mass, and this is not the renal mass. This is a huge, what we thought was a nodal mass, and you can see aorta being pushed. Another slice would show the whole hilum completely encased. So in some settings, I mean, who would be keen on operating on that? He's an intermediate risk, very fit patient. Who would think that we should take everything out? There was no other distant metastatic disease. Is there anyone who would be in favor of just take everything out?
So, I mean, really depends upon your availability of expertise and vascular surgeon around. This is a difficult case, particularly with very poor visibility of the hilum. Yeah. The hilum is encased, and we end up doing quite a lot of these cases. Really a nightmare at times when you cannot feel the artery. So you really have to cut into the tumor to be able to explore the artery and then subsequent dissection. So difficult cases.
Yeah, thanks, Prof. Yeah, that's what eventually we decided, that surgical, obviously complications is one thing, but more than that, even if we deal with that surgically, how would be the future oncologically with disease progression? So, so not for CRN, and even in a short time period, he has further progression during SACT treatment, which again shows that this is probably not the best of the cases to proceed with. So ASCO came up very recently after this in 2019 with an intermediate IMDC risk population, a subset of that with a median follow-up 61.5 months. And they have, that study has suggested about, this is something I just learned 2 days back during a webinar we were doing, that cytoreductive can be beneficial with only one IMDC risk factor, especially if they have only one metastatic site. This is for intermediate risk group. And delayed nephrectomy after initial systemic treatment in good responders associated with longer overall survival. So this again supports that there is a subset of intermediate risk who should not be denied of cytoreductive nephrectomy, and you should need to know your own outcomes, your own cases, and your own results. So we'll very briefly touch on the CERTIME trials because CARMENA was the main talking point, which compared immediate versus deferred cytoreductive nephrectomy in patients with synchronous metastatic RCC receiving sunitinib. So CERTIME randomized control trial, and that has a very briefly prospective study, and patients had upfront nephrectomy followed by sunitinib versus the other way around. So it has suggested longer overall survival with deferred nephrectomy than with initial nephrectomy. But the study was underpowered, seriously underpowered for the evaluation of the survival endpoint. The recruitment was very poor. So any observation that should be taken as a hypothesis. It was the progression-free survival was the primary endpoint, and the sample size initially aimed was 458, but it was always all down to 99 patients. So it closed after under 6 years. So, yeah, I think I've mentioned the point again. Any observation is hypothesis. Again, based from personal experiences, it's very difficult if patient is started on sunitinib. If I go by case, if they're responding well, then it's very difficult to decide when to stop and put the patient on, have the surgery done. And if they're progressing, then would the surgery have a good outcome or not? So I don't think I need to say more about SURTIME more than that. So both trials had limitations. Both trials recruited patients with high metastatic median volume. That is something to be considered and should not be used to abandon cytoreductive nephrectomy in patients with low volume metastatic disease, a good performance status, and favorable, of course, plus minus intermediate risk, where you can remove a fair bit of bulk of the disease. And after that, SECT could be delayed or avoided all together. So yeah, that's about it. Thank you very much.
Okay, great, Zeeshan. I think you have very nicely talked about this difficult subject. I remember a very nice talk by Mr. O'Brien from Guy's Hospital, forgot his first name.
Tim O'Brien, yes.
In the last, Tim, right? So on metastasectomies and IVC thrombectomies, these are very demanding surgeries. And this is really not, and Mazhar has also commented that these are difficult surgical procedures. At times, you feel that you're not confident enough to do these things, and these patients end up having systemic therapy, the response to which is very variable. So at best, there's about a 20% response rate, partial response rate. Complete response in these cases is very, very anecdotal. So my question is, and I would appreciate, we have about 15 minutes, so I would appreciate audience to please write down in the chat box questions, and if you have any comment to make, please raise your hand and your mic will be opened by the organizers. So my question to you, Zeeshan, is that what is the role of biopsy, and what would you do if you find that you're not dealing with a clear cell carcinoma?
So based on radiological diagnosis, if we feel this is not a clear cell carcinoma, then definitely biopsy could be considered to rule out lymphoma if this is what the concern is. Clearly, with papillary, again, my understanding is that we could go ahead with the same treatment pathway as we would do with clear cell. But definitely for lymphoma, we do come across cases occasionally where we have some doubts, and we do perform a biopsy beforehand. We almost had done a nephrectomy on a similar case, except that before biopsy, MRI clarified as well that this is not looking typical RCC. So we clarified with that and then went to have a biopsy. Yeah.
I mean, besides lymphoma, obviously that's a different situation. But what about papillary type 2 cancers or oncocytics and some of the other histological subtypes of RCC? So would you go ahead and do the same? And I know that it's really an oncology, but what consents to follow the same path of systemic therapy? There are specific different drugs available.
With papillary, I'm not entirely sure that from an oncological point of view, yes, with papillary type 2, which could be really aggressive, the oncologist may consider a combination of TKIs with the new generation immunotherapy. But generally, if we are to go ahead and do cytoreductive, if the patient is suitable for that, we would go ahead and follow the same. If biopsy has been done, let's say for whatever reason, and it does not show clear cell, but one of the RCC. What's your opinions, sir? On
well, I know that there is a lack of data, and SURTIME did include non-clear cell tumors as well, but the subset is so small that you cannot make any judgment. So currently, you are right that there is no specific drug which is for non-clear cell tumors. So essentially, you follow the same thing, and with the hindsight that they may or may not respond, because in all studies, the overall proportion of these non-clear cell tumors have been on the lower side. We have Dr. Mazhar Sheikh's hands up, and prior to that, Dr. Nazim. Nazim, you want to go ahead first, and then Mr. Sheikh.
Thank you very much, Dr. Ahmad, and thank you, Dr. Zeeshan, once again for joining. So just a comment. So about the, so can you hear me?
No, your voice is breaking. I think there's some internet connection issue. Please go ahead and try again.
Right. So can you hear me now, sir?
Yeah, it's better now.
Right. So you mentioned, Dr. Zeeshan, about the historical study by Flanagan. So from the cytokine era, then this this targeted therapy era, SURTIME and CARMENA trial. So in the era of these immune checkpoint inhibitors, so can we, generalize the results of SURTIME and CARMENA trial over the role of immunotherapy, particularly this pembro and exitinib, etc.?
So you mean apply those results with TKIs to the modern immunotherapy? Yes, if this is what you're asking, because I think obviously new trials need to be set up for them as well as a combination of TKIs plus immunotherapy. But that's how I think the whole history of cytoreductive have been, that previously it was with interleukins and interferon, which were applied with the TKI eras. And now the TKI is getting applied with the modern immunotherapy drugs on their own or combination. So I think unless we have more clinical trials, including them, yes, we would. That's I would support with any oncology colleague who is applying those with the current oncological drugs. If this is what, Nazim, you were asking.
Right. Mazhar, would you please go ahead?
Thank you, Professor. Excellent talk, Zeeshan, as always. Just want you to know your point of view, and Professor and rest of the colleague. I don't think so we can give any systemic therapy without having a tissue diagnosis. Is the standard of care? No,
these are cytoreductive cases. So we have
after the surgery you are doing. Is this what you are saying? Okay.
Yes. These are cytoreductive cases. So we have the specimen, we have the pathology from the.
I was a bit confused, like you have a disease which has recurrent sort of scenario, and or you have a primary pathology which has not been resected, and we are talking about systemic therapy. That's great. Thank you. The other thing, as Professor Nizam and Zeeshan has alluded earlier, that the data is emerging still regarding the non-clear cell cancer role of systemic therapy. So I think a few more years will going to give us more information, which we are waiting, especially with the targeted approach. Thank you.
So I think, Mazhar, what you are raising is a very important question about the biopsy. And we know that imaging has advanced significantly, and we know in majority of situations, it's a pretty straightforward imaging diagnosis that we're dealing with locally advanced or metastatic RCC. However, lymphoma is what Zeeshan mentioned, and there are various sarcomas which have invaded the kidney starting from either the kidney capsule or starting from the retinal peritoneum and going into the into the kidney. And often it is difficult to really ascertain whether it is originating from the kidney or going outside the kidney. So rhabdomyosarcomas and all kind of leiomyosarcomas are something which can happen. And if you've been heroic and going in and operating on these cases only to find on histopathology that they're not RCC. So I think biopsy should be used if there is any doubt. The appearance is not typically that of an RCC.
So yes, Prof, on that, I would like to just mention, which will clearly support your point. This last case of this young lad, at some point we had thought of it sarcoma, and the case was actually went to Glasgow, who are the regional sarcoma centers, and they had the biopsies done, and we were, I have to say, quite sure that this was a sarcoma until the biopsy came back. So yes, absolutely agree with your point here. Yeah.
Nazim, again, you have a query. Please go ahead.
Thank you, sir. So I think Dr. Mazhar has pointed out about the role of biopsy, and in both of these two trials, SURTIME and CARMENA, all the patients had a pre-biopsy done, and all patients had clear cell renal cell carcinoma. And all these patients did not have any brain metastasis. I mean, the patients who had brain metastasis, they were excluded. So this was just a comment. The question, Dr. Ahmad, is, I mean, you showed your patient's image. So if a patient, in your patient, there is a renal vein thrombus. So let's suppose if a patient has a small renal mass and he presented with a synchronous metastasis. So considering it to be a metastatic tumor, so would you do a partial nephrectomy or a radical nephrectomy? Obviously, if it's a favorable on the renal, or or do a classification if it's a favorable tumor. So do you think that partial nephrectomy would be sufficient?
I mean, in that case, if you forget about everything else, that he has lung metastases, he had mediastinal, he had pleural-based, parenchymal, and effusion, and all these complications in the lung. And we forget about the aortocaval and the paracaval lymphadenopathy, and you have an isolated IVC thrombus, not really IVC, this is more of a renal vein level 1 thrombus, hardly reaching IVC. Would you consider for partial nephrectomy if it is a T1A cancer? No, I would not. So as far as the data currently stands, what you are dealing with is a higher stage disease if you have an IVC involvement. If you are doing just a reduction of tumor mass or removing a kidney mass and then systemic treatment and so on, maybe, but no, generally a partial nephrectomy should not be considered for anyone who has more than T1B disease, at times T2A. But IVC thrombus or lymphadenopathy or metastatic disease, I don't, and I would appreciate comments from Zeeshan and Mazhar on this issue as well.
Right. So no, I'm sorry, I could not clearly portray my question. So not in this case, but for example, if you have a T1 case, maybe T1A or T1B, no renal involvement and lungs involvement. So in that case, would you go for partial nephrectomy, or which can easily be surgically resectable partially?
Hamasa, I think you are mute, sir. Sir, you're mute, I think. Yeah.
So Nazim, I'm sorry, I missed your couple of sentences in between. So you're saying that it's a small renal mass with IVC thrombus?
I think what Nazim is saying is low volume metastasis.
Low volume metastasis. I personally would not, because I think we are dealing with the disease, which is much more aggressive. Your imaging may be underscoring this disease. Often you will find sarcomatoid changes in these tumors. Often you find that there are variant histology as well. So the primary renal cell carcinoma, which is a small T1A, T1B with metastatic disease, there's something else happening. And I think partial nephrectomy is not a viable option, but opinion from Mazhar and Zeeshan.
Yeah, so I would agree with that. I think as a principle, Nazim, I don't really go for that, even if it's in a fairly friendly position, if it's metastatic disease, because like Masa was saying that these are aggressive tumors, that's the message. Although technically, if you have got negative margins, then fine, okay, you've taken that out. But as a principle, if the other kidney is functioning, and it's not a single kidney, then I would go for radical nephrectomy.
Thank you very much, sir. Just one more comment. Sorry, I'm asking you a few comments as well. So again, because the topic for today's study was CARMENA and SURTIME trial, and the criteria used were Motzer criteria and IMDC criteria. So none of these criteria, they have disease, you know, as factor. The metal
again, I think Nazim, there is this internet issue at your end. So we are also running time. Could Zeeshan, you or Mazhar have understood the question? You want to take it up?
No, not really on this occasion. It was
okay. So I'm sorry, Nazim. I think we'll have to take it personally at some other time. So I'm really grateful to Zeeshan for this wonderful presentation, his experience in cases, and the current paradigm in the management. Although we have high-class evidence, at least according to the reported literature, but there are problems with these two trials, as is very well pointed out by Mr. Zeeshan Afzal. And thank you, Mazhar and Nazim and all other colleagues who have very actively participated in this. On the third Saturday of February, we have the next lecture, this next CPU on urolithiasis this time. And there will be a case-based discussion on various interesting cases on urolithiasis. The cases will be presented by Nuvo Holz. Most of you know him. He has been, again, very actively involved in our clinical activities, our teaching activities. And we will also have the pleasure of having Dr. S.K. Pal, a very well-known figure in urolithiasis and particularly PCNL. And we will hopefully have one or two panelists again from Pakistan or from elsewhere. But for the time being, these two gentlemen will be there. So 19th of February, 7 p.m. Pakistan Standard Time. Hope to see you again. And thank you very much for these wonderful presentation and for a very active audience.
Thank you very much for inviting. Thank you.
Thank you, and have a very good evening.